Okay, everybody, our final set of videos for not only this week but this class. We are going to talk about our vascular diseases that are going to impair either cardiac function or pulmonary function. So let's just dive right into it. The first one we're going to talk about is MI. I mentioned in the previous video I saved MI specifically for vascular diseases because the origin of this problem is a vascular problem in a lot of the cases. There's typically a blood clot or a plaque that breaks loose in the coronary artery and completely restricts or partially restricts blood flow to the heart, which starves that heart muscle of oxygen. And of course, that heart is always pumping and it's consuming a lot of oxygen and nutrients, and you have to make sure that enough oxygen and nutrients are delivered to that heart, or it's not going to be able to produce enough ATP, which means it can't run those fancy little sodium potassium pumps and depolarize, repolarize, which means it can't contract and relax effectively. So all of that is traced back to a lack of blood flow, which a lot of times is a vascular problem. So what other things can cause it besides a blockage in a coronary artery? It could also be ineffective CPR. I know some of you guys have already done CPR training, but if you haven't, you'll learn about the particulars of what they call high quality CPR, high quality compressions and ventilations and things like that. There's a very particular way that they want you to do this. It's a little bit different with kids and babies and things like that, as you imagine. But overall, there's a correct and an incorrect way of doing CPR, and it's all about making sure you're doing it in such a way that you're generating enough cardiac output and perfusion so that you're supplying blood to the necessary organs, but also the heart itself. Because if that heart isn't getting its own blood flow, it's never going to restart, and all the CPR efforts are they're all wasted. They're all for naught. So this can actually happen if the heart is just without blood flow for too long because of something like ineffective CPR, drug abuse. So that's again the stimulant drugs that make the heart beat really fast, consume a lot of oxygen, and end up consuming more oxygen than is delivered. Cocaine is one of those drugs in particular because cocaine not only is a stimulant, it makes that heart beat hard and fast, consume a lot of oxygen, but it also has a nasty side effect of constricting coronary arteries. So at the same time, while your heart is beating fast and demanding a lot of oxygen, the coronary arteries are simultaneously narrowing. So that gives you an idea why certain types of drug abuse can lead to MIs, blood loss, just because there isn't enough blood to circulate to the heart, so it ends up running out of oxygen, or basically that ties in with severe hypotensive episodes from things like sepsis, shock, cardiogenic shock, whatever it is. That's all of these things can potentially cause the myocardial tissue to infarct, and as we know, an infarction is actual death of tissue. So the overall progression, let's type this out here so we're all square on that. The overall progression, once you stop delivering an adequate amount of oxygen to tissues and we kick off this whole ischemic process, you have the ischemia, which we know is just the loss of oxygenated blood flow. Or let me rephrase that. It's a well, I guess that's good enough. We're not delivering oxygenated blood flow anymore. Whether that blood doesn't have oxygen or there isn't actually blood flowing to it, we're causing ischemia. So that ischemia eventually injures the tissue. So we have injury, and that's because those cells are having a hard time functioning because without oxygen, they're not able to generate an adequate amount of ATP. They still produce a little bit of ATP through anaerobic metabolism, but for reasons that we'll learn about, that's not sustainable. So eventually that ischemia leads to injury, injury, and then the inevitable infarction. So that's the overall process. You start up here, you have your event, and the tissue becomes ischemic. Make that line a little thicker. We go that way. You have the ischemia, that tissue becomes injured, but it's not quite dead, it's just dysfunctional, it's injured, it has the potential to repair. And then eventually, if it's starved of oxygenated blood flow for too long, it will eventually infarct and those cells will actually die. So when they say myocardial infarction, that means we've gotten to this point. So We hopefully catch patients when they're in the ischemic stage or just starting the injury stage, because we can potentially get them reperfused. We can open up those arteries and stop them from infarcting, or if they have already infarcted, we can keep the area of infarction minimal. So that's the goal moving forward. So if we're following along in our PowerPoint, we're at slide 14. So it says here the area of injury does not depolarize and repolarize in a normal fashion, and this creates distinct changes on the EKG. This is like your STEMI versus NSTEMI. You guys have probably heard those terms. I don't know if we're actually square on what all those mean, so let's type those out. So STEMI equals ST elevated myocardial infarction. So that's the STEMI, S-T-E-M-I, STEMI. ST elevation, of course, referring to elevation of that ST segment on the EKG tracing. We're not going to go over specifics of why that happens on the EKG in this particular class, or really cover a lot of EKG examples. That's something that we cover in later classes, assessment and hemodynamics and things like that. But for now, we just need to know that once one of those arteries becomes blocked or narrowed, or the heart's starved of oxygen, that heart muscle is physically starved of oxygen, it's going to create distinct changes on the EKG, depending where the blockage is and if it's a complete or a partial block. So that's the STEMI versus the NSTEMI. So STEMI is ST elevated MI. If we throw NSTEMI in there, so NSTEMI, that would just be a non-ST elevated myocardial infarction. So it doesn't necessarily mean that the ST segment is normal, it just means it's not elevated. A lot of times that ST segment is depressed in NSTEMIs. So ST depression is different than ST elevation, and I promise we will cover that in later classes, or if you really want to read into it, I'm sure probably the EKG book does a very good job of explaining it, but we will cover that in later classes. For now, we just need to know that it does create distinct changes on our EKG. STEMIs tend to be more severe because the ST elevation, not depression, indicates that there's a transmural infarct of cardiac muscle. Not just a small part of it, but the entire thing. That's what transmural means. It's through the entire thickness of the wall. So it's not just a little bit, it's a whole lot, and I'm going to draw a picture of that here in a second. The NSTEMI is due to infarction of subendocardial blood tissue, cardiac tissue. So there's a reason that happens at the subendocardial level. Again, I'm going to draw that out here in a second. And some other changes that we can possibly see associated with MI is that T wave. If you guys remember back to EKG interpretation, it usually points upward in lead 2. We're going to see it invert and point downwards. And then as this gets worse and worse, we start to see prominent Q waves, which usually aren't very prominent or noticeable. All of a sudden they become very prominent and obvious. So a bunch of different changes that can kind of clue us in that there's an MI, and then definitely when we see that ST elevation or depression, the NSTEMI, it tells us that we've got significant problems. So let me focus on this here for a second, this layer. So instead of me drawing it over here, well, I guess I'm going to have to draw it over here. So let's say, here's my, I'll try to mirror that drawing right over here that you guys have on your slides. So that's our endocardium. And just like your vascular endothelium, the endocardium, so we'll just label it right here. That's the layer that's actually inside the heart. That's the surface of the heart that's actually in contact with blood flow, and it's very, very smooth. Just like the very inner layer, the vascular endothelium, the part that's actually in contact with the blood that's flowing through the vessels, that layer naturally is very, very smooth. We like blood to flow over smooth biologic surfaces because that keeps it flowing nice and steady and it doesn't clot. The second blood has to flow over a rough surface, or it flows over a non-biologic surface, that tends to initiate the clotting cascade, and we start forming blood clots. So we don't want blood to flow over rough tissue, and we don't want it to flow over non-biologic surfaces. because in most cases it's going to cause the blood to clot. But anyway, just a little explanation that endocardium, just like the vascular endothelium, is very, very smooth. And then behind it, we have our big, thick muscle layer. So when we say myocardium and myocardial infarct and all these different myopathies we're talking about, it's right here. So this is cardiac muscle. This is the good stuff. This is the stuff that has to beat regularly with enough contractile force and beat in a rhythmic fashion, depolarize, repolarize. That's the fancy stuff. That's the cardiac muscle. And then, of course, you have a protective outer layer. You have a pericardium, and it's very similar to your pleural layers in a sense that you have a layer that lines your heart and you have a layer that actually surrounds the heart. So visceral and parietal pericardium, and there's a tiny little cavity in there. And like I said, just like your pleural space, there's a tiny little bit of fluid in there that just keeps your heart wiggling around in there in a nice, smooth, frictionless, unimpeded fashion. So it's just like a little protective sac around the heart. I'm not going to draw that in this particular instance because it's not important. The next little detail that I'm going to put on here, so this is a coronary artery. It's not over here in this picture, but I'm going to put it in here anyway. So this is a coronary artery. And it supplies all the blood flow and everything that this heart muscle needs. And of course, it doesn't just run across the surface, just the big portion of it runs across the surface. And it's got little branches that go down and feed all the tissue. And of course, they branch out all over the place and feed the heart muscle all its nice oxygenated blood flow. The reason that an end-STEMI, this is just getting into some detail real quick, when we're talking about subendocardial blood tissue, I keep saying blood tissue, subendocardial cardiac tissue, when it's starved of blood flow, the reason that's the first stuff, so subendocardial, it's directly underneath, I'll circle it in green, it's directly underneath the endocardium. If we have a partial blockage in this artery, so there's still blood flowing through it, but there's a partial block, well, a lot of this heart muscle will still get blood flow, but some of it won't. And the stuff that's going to get starved of blood flow is the stuff that's all the way at the end of the circulation, all the way at the, basically think of it as the bottom of the myocardial layer, directly underneath the endocardium. So that's the subendocardial infarction. So that's your end-STEMIs typically, that's due to partial occlusions or other things that are just causing a decrease in blood flow to the heart muscle, not a complete cessation of blood flow. What happens in a STEMI? Well, what we're looking at is something much more severe in a lot of cases, and the example I'm going to use is a complete blockage. So now it's a complete block, nothing down here gets any blood flow, so everything, sorry, this is my infarct color. Everything down here infarcts because everything after that blockage doesn't get any blood flow. So that results in full thickness infarction, or what we refer to as transmural infarct. So that's why STEMIs tend to be much, much worse. Oops, I made it go away. I didn't mean to do that. Anyway, just a quick explanation why STEMIs tend to be so much worse than end-STEMIs. But don't get me wrong, they can both absolutely be deadly. STEMIs just tend to be a little bit worse. Now, talking about this infarcted area that I just made, let's switch it to spray paint. It'll be easier to cover this in. What? Where's my spray paint? There it is. Okay. So there's our big infarction. It's transmural. It's as bad as it can get. So this whole area right here doesn't depolarize and repolarize like normal cardiac tissue. It doesn't spread impulses like it should, which is why it creates distinct changes on the EKG. More on that later on. The size of this infarct is extremely important because how big it is going to basically determine the degree of cardiac muscle that is no longer functional. So bigger infarct, less functional cardiac muscle, worse cardiac function, but also the location. So if this happens, say, on the left ventricle, that's a huge problem because the left ventricle pumps most of the blood to the rest of the body, and you're going to have a hard time generating blood pressure. If it's in the right ventricle, you're going to have a hard time perfusing the lungs, as we might imagine. What if that infarction happens right around something important like a bundle branch or the AV node? Well, they might not lose a whole lot of contractility necessarily, but if they end up infarcting their AV node, then they have a permanent third-degree heart block and are going to need a pacemaker. So there's a whole bunch of different things that can happen in levels of severity when it comes to heart attacks, but they're all potentially deadly, and they're all very, very serious. So the size of that infarction, which is related to how bad the blockage is and how long it was allowed to persist, is extremely important, as well as the location. Where is the heart infarcted? And let's just know that a lot of these MIs, that's going to be a precipitating factor that leads to this patient developing heart failure, because the remaining good muscle is going to be overworked and not be able to keep up, and fluid will inevitably back up, and the patient experiences heart failure. All we're getting at is a lot of times we can trace it back to a previous MI. So signs and symptoms, how are we going to know that this is what's happening? Well, of course, if we get a fancy 12-lead EKG on them, and you are able to recognize certain characteristics of the EKG, you can spot right away that this is what's happening. But what about when the patient first gets wheeled in, or they just walk into the ER and they start complaining that they don't feel very good? We need to know our signs and symptoms before we get that awesome 12-lead. So the usual presentation of a patient with an MI is pretty recognizable, but we need to know that not everyone who's suffering from an MI is going to have this exact presentation. So the classic one that we're probably mostly familiar with is they're going to have chest pain, or what we call angina pectoris, or angina for short. It's going to be this constant crushing, radiating pain that goes to either their jaw or their arm or their back. Classic presentation is this crushing chest pain that feels like a ton of weight sitting on their chest. It's incredibly painful. It feels like just this crushing force holding their chest down, and the pain spreads out to their jaw and their left arm and shoulder. That isn't always the case. That just is with a lot of people. We're just going to be highly suspicious of any kind of chest pain when it comes down to it. So chest pain, whether it's on the front or the back or in the middle, or pain that's going up to their jaw, around their neck, out to their shoulders, anything like that, it can all potentially indicate that the patient's having an MI. So that's just a heads up if you ever show up at a hospital and you're ever complaining of any kind of pain in your chest. For the most part, even if you have, like, for example, even if you have indigestion, every now and then what people think is discomfort from indigestion is actually an MI. So a lot of times they're just going to get you a 12-lead EKG just to be sure. They're really, really quick at slapping all the electrodes on you and taking a quick electrical picture of your heart. So just so they can rule out. It would be one of those things that would be horrible to miss, and it's because not everybody presents with the classic chest pain radiating to the jaw and arms. So anyway, particularly women. Women a lot of times don't have that presentation. So anyway, moving on. Chest pain, constant and crushing, versus just when they breathe, which would be what we refer to as pleuritic chest pain. So that's an important distinction to make if someone says they have chest pain. Cool and pale. So that's due to the lack of perfusion. They're having an MI and their heart isn't working properly. So blood doesn't reach all their tissues necessarily. Blood carries a lot of heat with it. So they look pale as a result due to the lack of blood flow. And also they're cool because not a whole lot of blood is getting pumped out to their tissues. So if you feel their extremities and their hands a lot of times, they're going to feel a little bit colder than you would expect. Diaphoretic, why do they sweat? It's basically due to increased sympathetic outflow, catecholamine release. You guys are probably learning about catecholamines and sympathetic outflow and everything in pharmacology. Basically, your body is signaled to go into a hyperadrenergic state because it's experiencing a lot of stress. As this patient has a heart attack and their blood pressure is dropping and their perfusion drops, the body's natural mechanism is to release catecholamines to make the heart beat faster and harder, make the blood vessels constrict, and help keep the blood pressure up so we can perfuse all our tissues. Part of that stress response, part of that catecholamine release and extra sympathetic activity is sweating. So that's why these patients sweat. And it's not a slow onset, it's an acute onset. It happens right now. So the patient was feeling fine, and then all of a sudden they start experiencing all these symptoms. Nobody comes in with 3 or 4 days of ongoing chest pain and turns out they have an MI. It is possible for people to have a heart attack and not know it. Every now and then you'll do a 12 lead on somebody and you have a machine that's able to analyze the EKGs with a pretty fair amount of accuracy, and it'll pick up on old MIs that the patient had that they didn't even know about, which is kind of interesting. So just goes to show you they can be minor and unnoticeable, but it's still going to cause problems if that's happening. There's a reason that's happening, and it shouldn't be happening. Anyway, back on topic. Acute onset possible syncope, just meaning that the patient might have lost consciousness because their cardiac function is so diminished they're not perfusing their brain. And then, of course, the EKG changes we talked about. We'll get way in depth in those later on in future classes. So our classic presentation: cool, pale, diaphoretic with chest pain. That's the classic presentation of a patient with MI. So now we recognized them. What do we do about it? Well, the treatment initially is focused on reducing the workload of the heart, because we know that this patient, let's just say they're actually having an MI. We suspect it, they actually are having one, so our first goal should be to minimize the workload on the heart, because we know it's not getting enough oxygen delivered to it in the first place, so we need it to stop beating so hard and so fast. Among other things, we're going to need to try to open up those arteries in some fashion. We're going to need to stop more blood clots from forming, stop it from getting worse, and we're going to need to do something about our patient's chest pain. So let's get into it. So there's an old saying that Mona greets all patients with chest pain, and Mona is just to help you remember morphine, oxygen, nitroglycerin, and aspirin. So they all do slightly different things, but they're all aimed at essentially making the heart, the workload of the heart decrease, making the patient more comfortable, increasing oxygen delivery, and preventing more clots from forming or the current blockage from getting worse. So let's go over all of them real quick. Morphine's a pain medicine. A lot of people have heard of morphine. If you ever had a significant kind of like surgical procedure or procedural sedation or anything, sometimes they use morphine for that purpose because it's a very, very effective pain reliever. So why do they give them morphine or some sort of opioid if morphine isn't available? It's to decrease their pain, A, because it hurts, so we want to take away their pain, but it's also going to decrease the stress response. When patients are experiencing pain, one of the things that they do is they crank out a bunch of catecholamines like we just talked about. This is completely independent of the fact that this particular patient's having an MI. Any patient that's experiencing a lot of pain releases catecholamines. It elicits a stress response from the patient, which, among other things, raises blood pressure, raises heart rate, raises O2 consumption. A whole bunch of other things result from this stress response, which essentially leads to a hyperadrenergic state. So if we can help decrease the patient's pain, we're going to help decrease that stress response, which will decrease the workload on the heart. So the morphine serves kind of two purposes. Oxygen, that's to feed the heart with oxygen, of course, but it's a little bit more than that. You'll hear a lot of people say, oh, we just want to feed the heart with oxygen, make sure it doesn't get starved. That's awesome. I totally agree there. We do want to do that. But what the oxygen is really trying to do is eliminate any hypoxic reflex tachycardia. So if that patient even becomes a little bit hypoxic, or their body starts to pick up on the fact that they're not getting enough oxygen pumped around where it needs to go, one of the first responses is that their heart rate is going to kick up. That's just what your body does when there's a lack of oxygen. So basically flooding their blood with oxygen so that we don't have any of that reflex tachycardia, which makes the heart beat harder and faster and makes it consume more oxygen, which we just said is the exact opposite of what we want. So that's why the oxygen. Nitroglycerin we talked about in a previous video. It's any drug that has nitro or nitrate in it. We can almost bet every single time that that's going to be a vasodilator of some sort. So in this case, nitroglycerin happens to be very good at dilating coronary arteries. So if that coronary artery is blocked, well, if we dilate it, so let's dilate our blood vessel here real quick. So there's our big blockage. This is a problem, we all agree. But just maybe, especially if it's partially blocked. It's not completely blocked, but I'll just make the example here. If we can dilate this artery, so here we go, dilated. So it didn't get huge, but it did get bigger. And the result is that a little bit more blood goes through and starts feeding the myocardium. That's the idea behind the nitro. Nitro, it is a vasodilator, so if they take too much of it, it will drop their blood pressure even more and make problems worse. But if carefully dosed, it's very potent at dilating coronary arteries and not having a huge effect on the overall systemic blood pressure. But that can obviously be overdone if they're not careful. And then the last one, aspirin. Aspirin does something very specific. It decreases platelet aggregation, which is one of the early stages of blood clotting. So there's many other steps in blood clotting and things that cause blood clots to form. We'll talk about those later on, particularly in emergency care. But what this basically means is it stops platelets from sticking together. That's what platelet aggregation is. And platelets, we've probably talked about before, they're closely tied to blood clotting. So if you don't have enough platelets, it's hard to make clots. If you have too many platelets, you make clots too easily, and you have maybe problems like this. Either way, what we're doing when we give aspirin is we're trying to stop those platelets from sticking together so that they don't contribute to this clot here and we don't make new clots. So that's why Mona for all of our chest pain patients. So they're trying to hit the patient with all of these as quickly as they can, because at the end of the day, it either makes them more comfortable, it makes their heart relax, it gives them more oxygenated blood flow, or it stops clots from getting worse, which is exactly what this patient needs. In the meantime, we get that 12-lead EKG we talked about, and basically we're going to hand that off to the ED physician or the cardiologist when they get there, and they're really good at reading those EKGs and figuring out if it actually is an MI, and they can even figure out where that MI is. So they will just radio ahead or call ahead to the what they call the cardiac cath lab, or the catheterization laboratory, and that's where they do all kinds of cool stuff that we'll talk about in future classes, where they can actually thread catheters into the patient's heart while it's still beating, and they've got little balloons that they can inflate in the coronary arteries that open them up, or they can put stents in there that hold the arteries open. It's the whole idea of percutaneous coronary interventions is fascinating. Worst case, if that artery is completely blocked, like I had in my drawing earlier, and they just can't open it up, they're going to have to take that patient to surgery emergently and open up their chest and do what they call a CABG, or a coronary artery bypass graft. So that's the typical open heart surgery that most people think of, or if they say, oh, I had to get bypass surgery, that's basically what they're talking about. They had to go in, open up their heart, harvest a vein typically, or an arterial graft from somewhere in that patient's body, and then physically bypass that blockage by sewing a vascular graft from the aorta to the artery after the blockage, so that they can restore blood flow. So a couple of different options, and that's all dependent on if the patient actually gets to the hospital in time and all the correct treatments are initiated. So that's the basics of MI.